Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Hello everyone and welcome to PerfWeb Corona 30 Part 2, Day 5. We're at the end of our second week. Hope you've had an enjoyable and informative time over the past couple of weeks with 1 week to go next week. I want to thank our sponsors, if I may, LivaNova and Siemens Diagnostics. Both are very generous to us. Please check their sites out. I would appreciate it. It would help us. Social media, we are on all the platforms, Facebook, Twitter, LinkedIn, YouTube. Make sure you subscribe to our channel. Subscribers for us are critically important. We appreciate it so very much. And also click the thumbs up. No thumbs downs allowed, just thumbs up, and click the bell icon for the notifications as well. There's our email address right there, or a website. Check our websites out. I'm sorry, perfweb.us and perfusioneducation.com. I got ahead of myself there. There's our email address now. Contact@perfusioneducation.com if you'd like to join our faculty. You would like to present maybe a case. You are passionate about a particular topic or subject. Or you just want to be a panelist on the show, please give us an email. Or if you have a topic you'd like us to discuss, find a content expert for, or if you know somebody that has that interest, refer them to that email address, send us an email, we will get back to you. We're really building an incredibly large community, and we just really welcome continuing to add people to our programming. So our program today is going to be about, our phone line, I'm sorry. When you see this sign, phone lines are open, make sure that you go to your phone, call up, you can be live on the air, and so that's our number right there, and when you see that symbol, you know the phone lines are open and you can call into us. We have a really neat program today. We're going to be talking about a topic that I sort of took an interesting approach towards, but adequacy of how do we measure adequacy of perfusion? And then John Ingram, we all know John. He does a lot of our programs. He's become basically a fixture within the. There's John. Hey, John, within our organization and our programming, and we appreciate him so very much. Coming from work in Orlando, where he is the perfusion. How do I want to say supervisor? The perfusion support for an ECMO unit in a big hospital in Orlando. I think that'd be a good way to say it, if that works for you. So he's going to be with us, and then after he gives his talk on centrifugal versus roller pump, or just the nuanced differences between the two and where we are technologically, I guess maybe you may approach it from how did we get to how did we get to centrifugal pumps to start with, and now with the electronics the way they are, is it really cost effective anymore and necessary? I think I'm going to be real interested to hear what you talk about. And then we're going to be bringing in Stephanie Ebus and Amber. Oh my gosh, I forgot her last. What's her last name? I forgot her last name. Amber. Amber. Well, I'll get her last name and her bio later. I am so sorry, Amber, but we're going to be bringing her in and Stephanie later. And John and Stephanie and Amber and I are going to be talking about perfusion as a career and a profession or just a job. Just some perspective. It's a short 20-minute discussion on that point. So I'm going to jump right in and get started on measuring the adequacy of perfusion. And John, welcome again, and thank you so much for being here.
Good seeing you again.
Go ahead. I'm sorry?
Good seeing you again.
Yeah, I just appreciate you so very much. Okay, so it sounds like a simple thing to do, but in reality, measuring the adequacy of perfusion is really quite elusive. It's measured or assessed differently by many really excellent clinicians. There's a fairly wide spread of pressure acceptance, flow rates that are calculated and accepted. You know, I talk about flows, you go way back, and Dr. Shumway in California, at Stanford in California, in the early years, advocated for 30-30-30. That was 30 degrees, 30 degrees, 30 cc's per kilo of flow, and 30 millimeters of mercury pressure. That's 30-30-30. And he abandoned it because their neurologic outcomes were so horrible. So that ended that idea. It wasn't a good idea. Some people use pulsatile perfusion, some use continuous, and that's a big debate. Does pulsatile perfusion really create a physiologic pulse? And then when you look at the microcapillary circulation, the microcirculation, it's continuous flow at the capillary level. So do we really need a pulse to start with? So that debate has been raging on for a long time. Some people use vacuum assist venous drainage, others use kinetic energy, some use gravity. You have open systems, you have closed systems. You have temperature differences in drifting or cooling to 32 or cooling to 28. You know, for normal cases I'm referring to now, not necessarily, you know, deep hypothermia. Low flow states to facilitate visibility, how long that's tolerated for. The blood gases, we talked last night. John, you gave an excellent presentation on alpha stat and pH stat and how do we manage our blood gases. How much hypercarbia do we accept? Do we allow for that if we're doing TCD? Some measure, not TCD, NIRS, the cerebral oximetry. Do we use? Do we use it? Do we not use it? There's just so much variability. Electrolytes, where we'll accept our potassium to be. John, you were telling me about a situation where you had people freaking out because the potassium was 5.6, and you know, I've taken people off pump with the potassium of 7 and was not concerned about it. So, you know, it's sort of amazing to me that they would get that exercised over a 5.6, but, you know, to me that's within normal limits. You have metabolites, of course, and we look at the hemoglobin, who accepts higher hemoglobins, lower hemoglobins, what's your transfusion threshold. We look at other hematologic reports. We consider coagulation. What did you do? 300 per kilo, 400 per kilo. You want your ACT above 360, 400, 480. I mean, there's such variability in how people who are really good at what they do and have really good outcomes conduct their cases. And it's always fascinated me at how we as individuals believe our way is absolutely the best. And everyone else is, how do your patients even live? But they do. in a lot of different ways. There's a lot of different ways to do perfusion well. And I think really that's what makes it the art that it is. It's not an exact science by any stretch. And I think that when you consider artificial circulation and what it is we're really doing, a lot of the science, it makes sense in theory and mathematically, but doesn't always translate into actual physiology. So I just wanted to kind of throw out that initial set of thoughts. There's a very delicate balance. We need to do at the very minimum, the very bare minimum, because there's a whole bunch of other things. All of those things you see on the left side of your screen, in order to accomplish one thing, the reason we're there, the whole reason perfusion exists is to facilitate the surgeon's ability to do an operation. That's what the heart-lung machine was designed to do. But it's not just you turn the machine on and it runs. You got to do a whole bunch of stuff with that thing, because at the end of the day, it's not just facilitate the ability for the surgeon to do the operation. The patient has to be able to live and be able to remember who they are after the procedure is over. So, you really have to consider the complexity associated with doing something that seems relatively simple. We have one job: facilitate the ability to do the operation, I guess two, and not harm the patient in the process. So what humans tolerate in cardiac surgery is really remarkable. The durability of the human being is still to this day surprises me. But at the same time, we have this fragility. There's just, you reach a point, there's just a cutoff point, and that line is different for different people. But when you cross the line, it just really goes poorly. But up to the line, wherever that line may lie, it's remarkable at what we do. We go on bypass, and there's a lot of different ways to go on pump. Again, remember, everybody's got a different way, but it is not uncommon to open the venous line. The blood starts to rush back from the patient, displacing the prime in the line, or if you have a dry venous line, filling the venous line. Then it has to hit goes through the defoaming agent or area sock, and starts to fill the venous reservoir. Now, you have to have volume in that venous reservoir to start flowing. So you essentially are exsanguinating the patient. There's an acute exsanguination of the patient of several hundred cc's before you start flowing forward. Now you start flowing forward, and if you haven't mixed, you're going to have, 10, 15 seconds of just crystalloid going into the patient until the blood finally catches up and fills that line. That's why we used to mix back in the old days. John, did you ever mix?
No, I never did.
Yeah, we used to mix. We would take a little bit of venous blood and put a little arterial in, and take a little bit of venous blood and put a little arterial in. And we would do that until we became homogeneous. The pump circuit was homogeneous to the patient, and then we would initiate full bypass. And
Well,
it actually...
Well, you're saying you would drain a little bit of venous blood out, but give crystalloid into the arterial line? Is that what you're saying?
Yes, but it would be in small aliquots. So
right, so you're slowly diluting the patient instead of all at once.
Correct, yes. It would take took about 3 to 5 minutes to get the process done.
I've not
But
heard that. Interesting.
it really worked. It really worked. The place that I did it at.
Did you not have the drop of blood pressure when
Correct.
you went on?
That's right. We did not. That was what I was going to say, is that we would go on pump and you wouldn't see that big drop in mean arterial blood pressure until it finally will pick back up again.
Nice.
So we tolerate wide range of pressures. Pressure of 50, some places is where they keep it, 60, 80. Patient has any kind of carotid disease, they'll say, let's keep the mean at 90. But I show it in a slide later, but the normal mean arterial pressure is like 95. So I mean, it's not 60. Short-term shock from low flow periods is not uncommon when things happen and the surgeon needs the heart drained and can't see, and they need to turn the pump off. And we'll do that and we get nervous. Perfusionists start getting real nervous. We're like, it's been 10 seconds, it's been 15 seconds, and there's a clock running, but the patients tolerate it. And sometimes you have to do that repeatedly for a number of times to get the issue corrected. There's a loss of pulsatility. Does it really matter? Many studies demonstrate the disappearance of capillary beds during CPB, and I'm going to show you a video of that with either pulsatile or continuous flow. So, is the loss of pulsatility the reason, or is it something else that's occurring with the extracorporeal circuit? Because it doesn't really come back with what pulsatile flow we're able to generate from the pump, which tells me really I think the pulsatility may be non-physiologic. That's what I believe, because I don't think the pulse pressure is wide enough and the upstroke is too slow and the downstroke is also too slow. So, but there are a lot of studies out there that demonstrate the disappearance of capillary beds during CPB regularly, which may mean that, yes, the capillary system may be continuous flow, and they have certainly kept a lot of cows and people alive with continuous flow systems, total artificial hearts for, long durations of time. They last a lot longer, and people seem to adapt to it. But in the short term, it's hard for me to say that it doesn't make sense. You need the pulsatile flow for our normal physiology to work, that something about the macrocirculation is connected to the microcirculation, and pulsatility has some relevance to that. I just, of course, really don't know. Acute dilutional anemia, we do that frequently. We take people that walk in with hematocrits of 36, and then the next thing you know, their hematocrit is 22. There's abnormal stimulation of baroreceptors and chemoreceptors. So we do all of this at a minimum. Again, there's many other things. When we put people on cardiopulmonary bypass, it's a lot to do to a human being. This is a slide that I wanted to put up, and what's important about this slide, and it didn't, the slide got messed up when it got sent over, but if you look over here, at least I can't see it. I don't know, can you see a shadowed area right here?
Yes.
You can? Okay.
Yep.
So within that shadowed area that you see there, that is where your cerebral blood flow is auto-regulated. When you get out of that to the right or to the left, you lose auto-regulation. So you can see that auto-regulation really goes away when you get a mean blood pressure of below 60. Once you have a cerebral perfusion pressure, which would be on pump what would be our mean arterial pressure. So, and I thought that was very important. This is a good slide to have so you can reference it and understand that the brain requires a perfusion pressure. And what I think is when you go on bypass, and we talked with Dr. Garami last night about the capillary opening pressure, or the cerebral blood flow opening pressure that's necessary, and you go on pump and your pressure drops to 30, and we're treating it, but it stays at 30 for a while, and then it comes to 40, and then it comes to 45 or 50. And if you remember what he was saying yesterday, is that they had to go up above 60, maybe even to 70 to get it to actually that perfusion, the cerebral vasculature to open up and start allowing flow to continue to go through it in a homogeneous way using TCD as their guide. So when we come back up on flow and our pressure doesn't get up above 60, I think we need to start considering that's something we need to think about and say, maybe I need to bump it up. And then if they really want to bring it back down, we can bring it back down, but I need to make sure that I am opening the brain perfusion at that point in time. I wanted to show this slide. I thought this was a good slide. This was a fun slide. Let me turn my slides on over here. It's hard for me to see that far away. I'm getting old, John. Yeah, so this slide here endeavors to show where we have down here in the aortic. Here's the aortic chemoreceptors and the aortic baroreceptors. And so how many people, and I'm assuming you've seen it, John, have given a dose of cardioplegia, and as you're giving the cardioplegia, you have the root pressure is really going up, and then the next thing you know, your systemic pressure is going down. How many times have you seen? I've seen that a lot.
Oh, absolutely. The cardioplegia gets into the system and causes vasodilatation.
Yeah, no, that's the second thing. But I think too, it is a baroreceptor that you're increasing that pressure in that aortic root, and it's sensing that and vasodilating. Then you have the potassium on top of it that then kicks in. But I think, at least I think, the initial cause of that are these baroreceptors, but also the chemoreceptors. And I think that, a lot of people, even though we were taught this a long time ago, I think we've sort of forget that happens. And it's almost predictable, really. Mm-hmm. So what this video is going to show you, this is the actual microcirculation of a case that I was doing with one of my colleagues. And it starts off with they're cannulated, they're ready to go on pump, and then I'll tell you when they go on pump, but I'm not going to have to tell you. You're going to be able to see. Now, I took a screenshot of what we had done, so you see this right here. I'm going to be moving that around in order to, this one here. One of them, I'm going to be moving around to point stuff out, but that's from a different monitor. But this is the microcirculation here, these very small vessels that you see. This is the capillary system. These big vessels that you see here are predominantly venules. So what you want to see is you want to look at these small vessels that you see here. These are the ones that really matter. All right? So I'm going to turn it on and run it, and I'll tell you when we go on pump. Did I need to tell you? Or did you see it yourself? Did you see what happened there, John?
Well, it looked like you had a nice steady flow in the capillaries, and suddenly it became very irregular and sporadic and inconsistent compared to how it was prior.
And then what else do you notice about that in terms of the capillary density? How many of these little small vessels that you're able to see? Because what you see running through there are individual cells. That's how this camera works. You're looking literally at individual cells.
It appears to me as though about half of them are no longer perfusing. Like you've had a lot of capillary collapse.
Absolutely.
Especially there in the lower center of the screen.
Absolutely. Yes, absolutely. And I think that is the whole point of this is when we go on pump, and I hate saying this because you know how much I hate off-pump CABG surgery, but when you go on pump, this is very common. You can go back and look through various studies that exist, but I did it myself on a couple of patients, and have the camera, in fact. So I'm going to do it on some more once this COVID nonsense is over with. It's a lot of the fun things I wanted to do have been a little bit derailed because of what's been going on. But it's truly remarkable at what the effect of cardiopulmonary bypass is on the capillary system. Now, I kept this running. We ran it again. I didn't see it come back. I didn't see it come back for the duration of the pump run. So at first I thought, well, maybe it's just we're going on pump, we're getting a saline blast or an isolite or plasmalite blast, and so there's no blood. But then think about that. We're flowing non-heme directly into the brain. Maybe that's not such a good idea for a period of time. Maybe we should go back to mixing. But my point is that it never recovered until after termination of bypass and restoration of native circulation with pulsatile flow. We even tried pulsing on the pump. There was no difference. So I don't want to just show a bunch of videos, but it was really, really remarkable. And I would love to do a big study on this. I think it would be fascinating. I just need to find a place that is, more academic. I live and work in more of a community environment, but it would be a fantastic bit of information that we could get, and would be, I think one of those sentinel trials or sentinel studies that would really demonstrate things, because we could try different things to see if it reduces that phenomenon. So some understood parameters. I think everybody, there are some places that run their means about 50, but really I think most places are between 60 and 90. Normal is 80 to 95. So when we run at 60 or we run at 70, we're still 10 millimeters under. And think about a patient who has undiagnosed or untreated hypertension. How much are we increasing that patient's risk to acute kidney injury? We work really hard, I think, at keeping the acid-base balance as physiologic as possible within some, ranges. We frequently manage hyperkalemia, especially when you give a lot of potassium, a lot of cardioplegia. We give lots of sodium. That's something we give a lot of. Dilutional acidosis is not uncommon. We dilute out the bicarb when we use all of these crystalloids that are not bicarb based. All of our fluids, even though they're pH adjusted with acetate. So you dilute out when you're doing, let's say you have a K of 7 and you want to do CVVH on the pump. You run a hemoconcentrator, you pull off a liter, give a liter, pull off a liter, give a liter. You're diluting the bicarb. You're going to have to give bicarb. We've all seen that happen. I don't know how many times. So, that and that kind of a sodium load really isn't that good for you either. And we have to consider that. And then it is very uncommon. We've talked about it, I think you and I. It's not common in our practice, and I don't think it's that common around the country. I've been in a lot of places, talked to a lot of people, to measure lactates routinely on pump. And I'm going to show you something which I think is, important, because I'm kind of going somewhere with this, with a recommendation or a suggestion. Okay, so the body in all its complexity is really all about DO2, delivering oxygen to the tissue. We got to have it. Oxygen, or DO2, is another one of those obvious items we don't routinely measure, though it is extremely easy to calculate. The normal adult male runs about 950 mLs per minute, and the range for normal is between 750 and 1200 mLs per minute. But what's important is down here. And if you look at the side on the right, okay, the side of the curve is the normal state. Cellular consumption, VO2 is consumption, is independent of DO2. These cells depend on aerobic metabolism, we're familiar with that, and are not producing lactate. Moving leftward, as we go from here and we move leftward down the scale right here, we reach this point called critical DO2. When your DO2 has reduced to this level, which is the critical DO2, your cellular consumption is dependent on DO2. Cells would consume more oxygen, but there is no more being delivered, and these cells now have to depend on anaerobic metabolism, which produces lactate, and eventually, of course, untreated, they will die. So measuring lactate is now exclusively, there are always going to be some exceptions, I'll accept that, but by and large, if you're on bypass and you don't have some other phenomenon occurring where you have ischemia to a particular site that's not being perfused at all and coming back, you have no return from it, so you may not see that lactate, it may be severely delayed. Generally speaking, if you are not producing lactate, you are providing the patient with sufficient oxygen. If we measure DO2 and we know based on the patient's age, sex, weight, what their DO2 needs, body habitus, is it muscular, are they fat, what is it, skinny, we know what their DO2 needs to be, and if we're anywhere within that range, we're going to have luxurious perfusion. And there's a reason I say that. Not just good perfusion, luxurious perfusion, because there's other factors that are involved here. This slide I thought was very good at explaining all of this. If you look at the green line, you see that is your DO2. And you going from left to right, you can see it decreasing, but not just decreasing rapidly. It is simply decreasing. You look at the red line, and that is your arterial saturation up at the top, going from about 90% down to about 82%. But look at your purple line. That's the one that really matters. That's your oxygen extraction rate. And you can see as your DO2 decreases, your oxygen extraction rate starts to climb very rapidly. And if you look at the blue line, your SVO2 starts to fall almost as rapidly. So your O2 extraction rate is a very important thing to look at. A difference between the two are your oxygen extraction ratio, is a ratio of the body's oxygen consumption compared to the systemic organ delivery, or your DO2. So it is a ratio. Nevertheless, this is also a very good slide. And what you see here is, if you look, okay, here is your oxygen delivery going from low to high. Here is your oxygen consumption going from high to low. Here is your oxygen extraction ratio going from low to high. And here is your SVO2 going from low to high. And if you look at the intersection of the critical DO2, you see your lactates go well, and then boom, they start to climb, and they climb very quickly. Lactates will climb in correlation with your oxygen extraction ratio once that oxygen extraction ratio reaches the critical DO2. So a little more detail about oxygen consumption and the oxygen extraction ratio. The normal is about 0.2 to 0.3, which corresponds to an SVO2 of 70 to 80%. A high O2 extraction ratio, which means a low SVO2, is a feature of flow insufficiency. So you basically have a shock situation or low flow for any particular length of time. Anything that causes a decrease in cardiac output or an increased tissue oxygen demand. So you have to remember that. The oxygen extraction ratio, therefore, your SVO2, will be affected by not only low flow, but also increases or decreases in metabolic demand. A low extraction ratio, on the other hand, results in a high SVO2 and demonstrates either a diminished tissue oxygen demand or ineffective oxygen utilization by the tissues, or some sort of pathologically increased cardiac output, like just a very hyperdynamic cardiac output, which you sometimes see in sepsis, but well in excess of the body's physiologic requirements. Now, I'm going to tell you a case. I like telling cases. I love telling stories about cases, John. And if anybody can get this right, I'm going to ask a question. And if anyone out there can call in, put the number up, call in with the answer. I'm not going to say anything until after it's over. So I'm going to give you about 10 minutes. So there was a patient, and the patients, they were on ECMO, they were on VA ECMO. The arterial PO2 and saturation, PO2, and we'll just say in this case, PO2 coming out of the oxygenator was essentially the same. It was only 50 it was like 350, and the PO2 coming back from the venous access line, which was in the right atrium, was 300. If anybody can tell me why, and basically the blood gases were identical, but yet this was in the femoral artery, and there is no doubt it was in the femoral artery. That's indisputable. So we have to stipulate it was in the femoral artery. It's not a trick. The venous line was in the femoral vein into the right atrium. Absolutely cannulated perfectly anatomically. But for all intents and purposes, the blood gases coming out of the oxygenator and the blood gases coming out of the venous line were essentially identical. So you got about 10 minutes while I wrap up my talk, and anybody can get that answer, you get one of these fashionable perf web cups. You all have seen them. People are using them now as collector items. So if you got the answer, call in. So what are some of the factors that increase oxygen consumption? Well, surgery itself. You can see the list, but I highlighted a couple. Inflammation, because these are things that we're involved in. We're doing surgery. We're controlled trauma. Inflammation is going to occur from sternotomy, from going on pump, all that stuff, and adrenergic drugs. We give a lot of those, right? Factors, however, that decrease oxygen consumption: sedation and analgesics, paralytic agents, shock and hypovolemia, hypothermia, mechanical ventilation, and antipyretics, all of which we use. So when you look at the oxygen consumption of a patient that should be between 900 or 850 and 1200, that's for somebody who's standing up like I am, not the patient lying on the bed, asleep, paralyzed, on the anesthesia ventilator. You got to remember that. Now, some things we do to them may cause a little bit of uptick in that, but by and large, our oxygen consumption, our oxygen requirements are going to go down. But how far down, is really the question. An abnormally high extraction rate occurs during anemia. Well, we cause anemia. Of course, there's a debate. What's really anemia? Is 21 really anemia? Is 18 really anemia? Is under 30 really anemia? Those are different topics for different days, but there's wide variability, and I think a lot of debate that still rages to this day as to where a hematocrit should be on most patients and then certain patients. I think it needs to be individualized. A young, healthy 22-year-old that, let's say, got stabbed in the chest and needed to be put on bypass, probably would get that hole fixed, come off bypass with a crit of 16, and probably do okay. More than likely, good chance they would not need a transfusion, I think, and do fine. Even though I think they would get one in most institutions, I think you could get, but I think they could get away with that. But you take a 65-year-old diabetic, hypertensive, heart failure grandmom that you do a mitral valve and 3 bypasses, 3 jumps on, and you try to do that to her, or 18, even 21, it's a whole different ballgame. So when you have a low extraction oxygen ratio, low oxygen extraction ratio, one of the things that causes that is artificial circulation, interestingly enough. So I thought that was very, interesting. And they say on the heading that it's from increased oxygen delivery. So I'm assuming that's VA or is it VV. So I think that if you are on artificial circulation, such as ECMO, for a reason of having a hypoxic episode, and you're able to improve that with normal cardiac function, you're going to have a lower oxygen extraction ratio because you now have luxurious flow and oxygenation. The theoretical rationale for clinical use of oxygen extraction ratio may be used to assess flow insufficiency in critically ill patients. Look, I contend every patient that goes on cardiopulmonary bypass is critically ill for a period of time. Hands down, that's my belief. There is some evidence that high O2 extraction is associated with lactic acidosis, suggesting that it could be useful as a global index of tissue oxygen delivery. Shock is defined as inadequate oxygen delivery, or DO2. Thus, the oxygen extraction ratio should theoretically be a perfect representation for the magnitude of shock. However, lactate is a very easy test to run. So why don't we just run it? Why is lactate not routinely sampled on our pump blood gases? It is if you use like some of the point of care devices, they'll have lactate already built in, but most people never look at the lactate. And I know a lot of people that don't have it on their device and don't ask for it. But it's a perfect way to assess, am I delivering sufficient oxygen to this patient's tissue? Without all that other stuff that I just went through with oxygen extraction ratios and calculating O to VO2 and doing all of that stuff. All you gotta do is just run a lactate. The lactate's normal, you're providing plenty of oxygen to that patient's tissues. So what I did was I took this patient and I calculated their DO2. 62-year-old female, 162 centimeters, hemoglobin of 13.6, cardiac output of 4.8 liters a minute, and that's going to provide that patient with a DO2 of 728 milliliters per minute. Go on pump with 1,000 cc's of prime plus 750 of anesthesia volume and a flow of 3.8, your DO2 is dropped to 412 mLs per minute. Now, is that enough? Patient is under general anesthesia. The patient is paralyzed. The patient's on mechanical respiration. So their consumption of oxygen has gone way down. And then we haven't even considered temperature. Are we going to drift? Are we going to cool? What are we going to do? So you look at this graph here, and we all know this formula. In case you didn't remember it, it's 7% reduction in metabolic requirement for every 1 degree drop in temperature. Now you look here at this graph, and let's see if I can get this thing to work. There it is. I can't ever find it. There it is. 37 degrees, you're at 100%. But when you go way down here to 30 degrees, I didn't go too far, I just went to 30 degrees, you're at 60%. So that patient who was at 414 was at 56% of baseline. If they were at 30 degrees, without taking into consideration all the other factors that I have already previously mentioned and articulated that have reduced their oxygen consumption, their oxygen demand, that's plenty of flow for that patient, which can be validated by checking the lactate. I think you see where I'm going with this. My theme today is we need to check the lactate. Follow the lactate. Okay, so since I put the old phone booths in there, just because I feel that way sometimes. I'm feeling that way after these 2 weeks, and I'm feeling that way after this COVID disaster. Every television program I watch, every advertisement I watch has to do with COVID. Everybody, that's all they talk about is COVID, 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 COVID. And we ended up calling this the Corona 30, but it really is the Corona Beer 30. It has nothing to do with COVID. But the phone lines are open if anybody would like to ask anything, if anybody has an answer to that question. And again, you can have that stylish Perf Web cup. You've seen them on here before. They're really nice. Great to have coffee or cappuccino in, or something more sophisticated, because we're kind of sophisticated around here. John, you have any ideas?
I do know one thing that will cause that, and I do know a theoretical second thing that would cause that. I don't believe, however, that either one of my answers is probably what you're looking for.
Well, that's what I'm looking for. It's what it was. I'm not looking for anything. I know what caused it.
Yeah, well, I'm saying whatever really caused it, I don't necessarily know if my ideas are going to be that, but I do know one that will give you exactly what you're talking about. You want to hear it?
Say it. No one's called in yet.
I've seen this several times. If you're on ECMO and you're on VA ECMO like you said you were, and everything's fine with the cannulas, when the patient is
wait, somebody's calling.
Okay.
Did they call? Oh, what did they disconnect for? Okay, wait, John. You got to see. I already sent. I already owe you like 3 cups.
No, I don't. I have enough cups. I have a 6-pack of cups.
Can you call them back, Magic?
So I'll bring up a different topic if you want while the caller's calling back.
No, it's some overseas. I don't.
Oh, somebody overseas? Oh, okay. Try to call back. We missed your call.
I'll bring up a different topic for a minute while we're waiting on that caller. You were talking about all the different things that you said we have one real job, or maybe 2 jobs. One is to make so the surgeon can do his job or her job, and the other is to keep the brain alive and the rest of the body.
Yeah.
Really, that's really our 2 jobs.
Right.
But, if you look at, and then you listed all the different things that are going on that we have to worry about, this has been done. If you look at...
Answer. Sorry, John.
Yeah, it's good.
Hello, you're on the air.
Hi, good afternoon. I'm Karen.
Hi, it's nice to see you.
Hi, how are you?
Good, great.
Yes.
Where are you calling from?
I'm calling right now from Colombia, but I am from Venezuela. I'm having a good time with your talk today.
Thank you.
I would like to answer. I don't do ECMO procedures, but I read a little bit. Maybe the answer that the same PO2 from the venous return, it's because the patient has an atrial septal defect, maybe?
A dissection?
No.
That's a good thought.
She said atrial septal defect.
An atrial septal defect? Oh, that's a good thought too. But no, that's not the reason for this. No, but that's a good thought.
Well,
that was a good thought.
Well.
You stay on the line with us. Hey, listen, you need to put our email address up. What's your name, ma'am?
Okay.
What's your name?
Okay, my name is Karen Pertus.
Karen, oh, okay, I saw you on the YouTube. Look, send us an
Yes, on the chat.
Yes, send us an email if you would at contact right there. We just put it up. Send me an email because we're gonna send you a cup anyway.
Okay. I will send
But
you
stay on the line with
my
us if you'd
email.
like. I'll tell you what happened.
Okay.
John, what
Thank you.
what were your thoughts?
Well, I can tell you one thing that does cause this on ECMO, because I've seen it twice. If the patient is 100% deceased and you still have the patient on ECMO, your venous blood gases will be almost identical to your arterial blood gas.
No, you are correct. So, Karen, the answer, John got the answer correct. The patient had zero.
I didn't think that was going to be it.
Yeah, that was it. The patient had zero oxygen extraction because the patient was deceased and on ECMO. So they had blood flowing through their blood vessels, but there was nothing, there was no metabolism going on anywhere. And
the fluid is excessive.
it was horrible. It was horrible. But look, we need your address at that email address so that we can send you a cup, certainly, because we want to do that. So what hospital do you work at?
I am from Hospital Cardiológico in Venezuela. Yes.
Very nice. And how many cases are y'all doing down there?
Well, right now there is no surgical activity because of the crisis, the sanitary crisis. So, but we are a big hospital. Sadly, we do not perform the most of the cases we would like to because of the economical situation of my country. But we are a good hospital.
Yes.
With good people.
I have no doubt. And you said you don't do ECMO there?
No, we don't. We don't. At this moment, we don't. Only cardiac surgery, but without ECMO.
Do you see patients that you think might benefit from ECMO where you are?
Sorry?
Do you think that there are patients that would benefit from ECMO where you work?
Oh yes, absolutely. But at this moment, from a long time from until now, there are no performing complex cases. Only low complexity cases.
Yes.
But sure, I have no doubt that the ECMO is imperative to have the availability in this kind of hospital, of course.
Yes, of course, I understand that. Do you mind if I ask where you trained?
I trained in Venezuela, in Hospital Universitario de Caracas.
Oh, very nice. In Caracas, yeah. And then how long have you been a perfusionist?
I've been perfusionist for about 19 years.
Wow.
I graduated in 2001.
Wow.
Yes.
That's a long. That's a lifetime. You sound too young to have been a perfusionist that long, and you almost seem too nice. Most 20-year perfusionists are never really nice.
Yes, it's my life, I think. But 2001 was a different economical, political era in my country, but we take advantage of that at that time. But sadly now it's pretty much different. So.
I understand. Well, it'll get, you know what, it'll get better, Karen. It will get better.
Well, thank you. Thank you. I appreciate your sessions and your knowledge. I am taking notes.
Well, thank you so much, too. We're looking forward to communicating with you via email, and maybe one day we'll come down and visit.
Thank you.
Bye-bye.
Okay, thank you.
Bye-bye.
Bye. Good afternoon. Keep going.
Ciao. Okay. Where's John? Oh, he left? Oh, okay. That was good. That was really nice. It was nice to hear from Karen from from Venezuela, but calling from Colombia. She may be on vacation or something, I'm assuming. I didn't ask that. But Karen, don't forget, send us an email. Okay, so do you want to take just a brief break? And why don't we do that? Don't do the whole thing. Just put up the thing that you put up, and we'll just wait for John to get back and then dive right into his talk. So we're going to take just a short break, but we're not going to play commercials. We're just going to go to a certain screen. And everybody just hang on and be patient with us. Thanks. and welcome back, everyone. I think we're ready to dive right in to John's talk. So, John, if you're there.
Can you hear me?
I can now, yes. Can't
Okay.
see you yet. There you are. Okay.
Everything good?
Yes.
Okay, so great. That was a great talk, Joe.
Thank you.
I definitely have some more comments on that one if we get back to it, but I think we got a lot more still to go today, so we'll see. But this is just going to be a real good, hopefully fairly solid, not too long, concise review of a lot of the things that a lot of us have already learned and heard over our careers and our education, roller pump versus centrifugal pump. Okay, so let's see what we can dive into on this. And I think I've got everything on the slides, Joe, all at once, like yesterday. So this is going to be the outline of what I'm going to cover today. This is sort of the outline. I'm going to talk about what does the ideal or the optimal pump look like, what are the features that it should have if we were to have the most ideal pump. Then I'm going to look at roller pumps specifically, how they work, how to properly occlude the occlusion techniques of the roller pump. What are the advantages and disadvantages of using a roller pump? And I'm talking about on your arterial pump now, specifically. Then we're going to look at the same things for centrifugal pumps, how they work, the advantages and disadvantages. And then we're going to look at about a dozen studies where people have tried to figure out what is better, roller pump or centrifugal pump. Then we're going to conclude that and bring it all full circle again. So go ahead, Jim.
Oh.
And so what would be the optimal blood pump? Dr. Tayama, back about 10 years ago, he suggested that the ideal blood pump for extracorporeal circulation must have these following features. It must have the capacity to deliver up to 7 liters a minute against a pressure of 500 millimeters of mercury. It should not damage the cellular or acellular components of the blood. It should have smooth surfaces. It must be free of areas of stasis or turbulence. It should have accurate and reproducible flow measurement. And you should have a backup or manual mode of operation in case of catastrophic failure of the pump. Go ahead, Joe. All right, so let's look at roller pumps, how they work. So I've got two graphics there, but basically it's a propulsion of blood that occurs by the action of two or sometimes more, but in most perfusion cases, two rollers sequentially compressing a segment of tubing, causing the forward movement of blood. And so if you look at the right-hand graph there, this is essentially at the very lower part of that one on the right. It shows you that if you were to take a tubing full of fluid and run a roller over it, compressing it almost all the way down, of course, the fluid would move forward. And this is exactly in all that we're doing with our roller pumps that we use today. So proper occlusion is vital when it comes to using a roller pump. You have a couple different ways of doing it, and people listening at home, you're probably going to think to yourself, well, you have even a third or fourth way, but most of them are going to be very related to one of these two methods. One is called the pressure method. Now this one, the advantage is that you can do it with the circuit primed and sterile. So basically right before you do your case. You've primed your circuit and there's fluid in the tubing and inside your roller head. You then must have some type of pressure manometer integrated into the positive flow outflow line somewhere. You then tighten the occlusion of the pump pretty much until it's fully occluded, and then you clamp your outflow line somewhere just beyond the pressure manometer. Then you manually rotate your pump head until the manometer goes up and reads 200 millimeters of mercury. Slowly back off of the inclusion until the pressure drops slowly over a 1 minute period down to 100 milliliters of mercury. So it should take about a minute for it to drop from 200 to 100. And then you have to do the same for the other roller on that same pump. The other method you can use is a water column method, and for the most part, this particular technique I'm going to show you would not be done in a sterile way. You would do this in the pump room prior to your case at some point. You place the tubing inside the roller head, you get a bucket of water, you put both the inflow line and the outflow line under the water, and you circulate the water through your prime line. So basically you've primed your tubing. You then tighten the occlusion of the pump until it's fully occluded again. Then you take your outflow line and you hold it in your hand, hold it vertical with the ends of that tubing about 2 feet above the level of the pump head. Then you slowly back off your occlusion until the fluid level drops ever so slightly. And basically, textbooks and articles will tell you something like 1 millimeter a minute, which is just barely moving. I don't think anybody could actually time that, but it gives you the idea that you want it to be ever so slightly dropping. And then, of course, try to do the same thing for the other roller on the same pump. This is basically the two styles that people out there use, or versions of them. So what are some of the roller pump advantages? Well, it's less expensive. It's really just a piece of tubing. It's definitely lower prime volume than a centrifugal pump. It's just the tubing length that's going through the roller head. It's definitely easy to prime. You basically can turn on a dry pump line and prime it right through, and it primes almost immediately. Well, another advantage is that the flow is not afterload dependent. Now, I put an asterisk to that because that can also be a disadvantage, but the fact is that if you're flowing normally and things are normal, as your patient of your blood, as the pressure and resistance in your patient changes, this flow is going to stay the same. It's a reliable, constant flow rate, and it does not allow for retrograde flow, something that centrifugal pumps can allow. The disadvantages of it are that it's an occlusive pump, and it is not afterload dependent. So it will pump against any resistance and therefore may result in vessel dissection, pump tubing disconnection, or pump tubing rupture if the pressures get high enough. It's capable of pumping massive air through the outflow line. Go ahead, Joe. That's the occlusive negative. There's a preload dependent that's a disadvantage because it's highly capable of cavitation. Now, as the tubing expands beyond the roller, as the roller is going through the pump and the tubing is being compressed, there is a period of negative pressure. This is a momentary negative pressure right behind the roller. It's a momentary negative pressure in the absence of adequate preload. And it may induce the cavitation of air dissolved in the solution. You guys hear me okay? Yep. So another disadvantage would be that it can be implicated in hemolysis. Well, the magnitude of the hemolysis is related to both the time and exposure of the blood to the shear forces generated by the pump. That's actually true of any kind of pump. There's a region of high pressure and shear forces created at the leading edge of the roller where the tubing is being compressed. Now, you can have an over-occlusion, you can have an under-occlusion. If you have an over-occlusion, the roller will crush the cellular components inside the tubing, causing hemolysis. This is why you don't want a 100% occluded roller pump, and why I showed you those occlusion techniques allow for the ever so slight gap so that it's not completely occluded against itself when the roller comes by. There could be an under-occlusion. If it's under-occluded severely enough, you can have severe forward and backward turbulence causing shear stress and also hemolysis. Another disadvantage, go back one, Joe. Another disadvantage is spallation. Forward. Yeah, spallation. There's another disadvantage of roller pump is that particulate emboli may be generated by macrofragmentation, called spallation, of the inner surface of the tubing where the roller contacts the tubing and where the fold at the edges, the top and bottom of the tubing, where it folds together, where the tubing fold occurs. You can have the spallation, okay? Studies of tubing wear over time have shown that polyvinyl fluoride fragments generated from roller pumps are actually quite numerous and frequently as large as 20 millimeters in diameter, which sounds pretty scary. That would never make it past your arterial line filter, thankfully. But they actually begin to occur as early as in the first hour of use. Go ahead, Jim. So now, let's talk about centrifugal pumps and how they work. Well, they're a non-occlusive pump, and they function by producing a constrained vortex within a polycarbonate structure. The inner mechanism may either be cones or impellers that rotate at a very high RPM. This high RPM exerts an outward centrifugal force on the blood where the outlet is located, where it then exits the pump and results in a forward movement of the fluid. The blood flow rate is increased by increasing the revolutions per minute, the RPM, thereby increasing the centrifugal force that's exerted on the fluid. The disposable pump head is coupled to the console unit via magnetic motor drive. So here's a couple diagrams. You have the, if you can see the inside mechanism of the pump on the left, this pump is basically using more of an impeller or fins to push the blood forward. And then the other on the right is really a series of stacked conical shaped cones generating a true centrifugal force. The advantage of the one on the left, it would be able to run at a lower RPM because it's physically fan paddling the fluid forward, whereas the one on the right really relies on centrifugal force solely. So as I said about the magnetic coupling, these disposable pump heads you just saw need to go into some type of console unit. The disposable has a magnet on the base of it, and that couples magnetically with the console unit. The console unit then spins and causes also the disposable unit to spin at the same speed. But you can have decoupling as well, right?
Yes.
We're going to talk about that. So some of the disadvantages. Some of the advantages of centrifugal pumps. It's non-occlusive, so it will not pump against any resistance. At a certain resistance, it will no longer continue to pump. It is afterload dependent. You have too high of an afterload, it'll pump either less or nothing at all. It's less likely then to result in vessel dissection, pump tubing disconnection or rupture. That's different than the roller pump model. And the pump is preload dependent. I'm not sure what I'm looking at with that graphic there. What is that? So basically, if you have a centrifugal pump and you clamp or occlude the inflow line, it will also stop pumping, okay? It will also deprime when challenged with gross air, for the most part. I'm not sure what that graphic is there, Joe. That's some type of contamination on the download. So what are some of the disadvantages of centrifugal pumps? Well, they're more expensive. You're going to have a larger prime volumes, quite a bit when you compare it to just a straight piece of tubing going through a roller pump. It's going to be more difficult to prime. You have to manipulate the pump to completely de-air it, whereas with a roller pump, it's going to push the air right through and prime itself. And you can have retrograde flow occur with a centrifugal pump. Remember, it's relying on the amount of RPMs that you're telling it to run at to continually push as a positive direction. If you decrease those RPMs, you can either have zero flow or even a negative flow. But it's far less likely to result in vessel dissection, tubing rupture, disconnection.
Hey, John.
Would
it bother you if I interrupted you for a second and asked you a question?
Right ahead, yeah.
You sure? Okay. So on the retrograde flow, there's been debate about having a one-way valve in the arterial line, the main arterial line, to avoid that problem. It's the typical duckbill valve, which would work, very effectively. But people are very hesitant to do that because if you did get air into your centrifugal cone, it's very easy to take it out, put it, rotate it so that the outlet is facing straight up to your oxygenator, and then in a controlled fashion, open that line and let it reprime, and then put it back in and go back on pump and not have any problems with it. What are your feelings about that, about the duckbill valve, no duckbill valve, and the risk-benefit of that?
Well, I did work at a place where we had that, but not that it's ever happened to me, but I know, I'm talking for a friend of mine who had the same thing you just occurred, where, did get air in the centrifugal pump and did exactly what you said. And actually, when you take it out and lower it, and you're going to have some positive pressure in your patient, and that's going to push that air right backwards back into your reservoir very nicely.
Yes.
And the only way you know that works so well is if your friend who did this instead of you can describe it to you very well, and you know how well that works.
Yeah, exactly. With the
you're right. I didn't think about that with a large one-way valve in line. I guess you're buying one thing and giving up another. You're buying the fact that you can't have retrograde flow, but I guess you better never get air in it, because I guess you'd have to walk it back, and it would take a little longer, because when the blood comes rushing backwards towards you, it really moves that air back into your reservoir nicely.
Yeah, you have to be very careful. Right, you have to be very careful. I would suggest, just as a caveat to this, that like you, I have a friend that did the same thing. And, you do it and you get it back up, but you have to take just a minute to take a peek over the shoulder and make sure that when you did come back, you didn't entrain any air around the cannula, because then you're going to have to deal with that aspect of it too. So you just have to be aware that can happen but generally if the patient's full, it's going to take a while before that blood goes away. They're going to have a pretty good pressure, and just don't do it super fast. Just open it up in a controlled way, and it'll just back bleed right into it, and then you can put it back in, and your venous return is caught up by then, and you go back on. And the whatever air there is, it's not going to go anywhere. But I fortunately have never had that problem. But I do know that my friend said he checked to make sure that the line of the coming out of the aorta was clear.
Yeah, and my friend told me too that it feels like forever when you're doing it, but you actually end up doing it very quickly. And the patient, if you're running the pressures like you're talking about earlier of 60 or greater, a lot of us now running even 70. And when that happens, and you're going to clamp your line, and then you pull that pump out and you open up the inflow line, you've got a pretty decent positive pressure in your patient, and you only need a couple seconds of that backflow, and that air goes zooming right back into your reservoir, and you scramble, my friend scrambled to put it back in as fast as possible and go back on, and he tells me nobody even noticed what happened.
Yeah, well, I heard anesthesia noticed the pressure had dropped so very dramatically, and my friend told him to flush the line. Yeah, you need to flush the catheter, and by then they were back up to full flow, so it was fine.
It pays to have good friends, doesn't it?
It does.
Yeah, so go back one. So apparently, I was backward. Yeah, go back forward. So so we were talking about allowing for retrograde flow, and I guess this slide got contaminated with the other one, because it says there it's less likely to result. That's actually an advantage. So let's just go past that one, because we're talking about disadvantages. One of the disadvantages too is you can have thrombus formation in these pumps, and usually it would happen in cases of too low of anticoagulation, or long pump runs can sometimes happen too, like in ECMO, for example. You can have heat generated by these pumps. Now, things have gotten better over the years, but years ago, Joe, if you remember, some models came out, they generated quite a bit of heat, and this could be a concern for hemolysis and even clotting. And then magnetic decoupling can happen, and what that is that you remember you have this magnet in your console that's spinning at a certain RPMs, and your disposable pump is connected with that through magnetism, but they can lose grip, so to speak. They can decouple from each other, and you'll hear that quite loudly on your pump when that happens. And what's happened is the magnets have let go from one another, and for whatever reason, the forces involved have become more powerful than what the magnets are attracting each other, and the pump's still spinning at a certain speed, and your pump head is no longer with it. and it's doing something else. So that's what we call magnetic decoupling. And usually, if you'll slow your RPMs down and let it get reconnected, you usually can be okay. So now let's look at some research studies trying to figure out which one of these, you want to go with. And in general, I'm going to make some general comments because a lot of studies support these comments, and there's too many to list. But a number of investigators have performed, and I'm talking about over the last many years, several decades at least, have performed in vitro studies comparing centrifugal pumps and roller pumps, and they were looking at in terms of blood handling during short and long-term use. And Tamari and his group examined hemolysis under various flow and pressure conditions using porcine blood, and they concluded that the hemolysis was related to, and this goes with any pump, no matter what it is, hemolysis is related to the duration of the blood exposure to whatever shear stress that particular pump is applying to the blood, the pressure head, the amount of pressure in your outflow line that you're having to push the blood against, and the flow rate of the pump. Those are three of the big key things. The duration of time, I'm sure, also. But those are big three things as to if a pump is going to be causing hemolysis or not. Many studies have reported less hemolysis with a centrifugal pump when tested in vitro. However, go ahead. Many trials have been conducted to compare centrifugal and roller pumps in relation to many things, in relation to emboli generation, blood trauma of all different sorts, denaturization, red blood cell trauma, and also try to look at, does the clinical outcomes matter? In a randomized trial that Wilden did and his colleagues, they found a centrifugal pump to have significantly less microemboli generation, less complement activation, and better preservation of platelets counts were observed in those patients as well.
When was that done? Do you remember?
Yes, yeah, I'm gonna have to. If anybody wants to know, there was so many references that I
is that old?
I don't know exactly. I'll send anybody who asks exactly those. Yeah. But if you search that last name, you'll find the studies that I'm talking about. But gotcha. I'll email somebody if they want to know. But a similar improvement in platelet preservation also in the centrifugal group was observed in a retrospective review of 785 cases, particularly with bypass times more than 2 hours. Now, rates of hemolysis have been compared in 7 randomized clinical trials. 2 reported greater hemolysis with roller pumps. 1 observed greater evidence of hemolysis with a centrifugal pump, and 4 found no difference between the 2 types. What I'm trying to drive home here is, and I'm going to say this at the end, there are probably just as many studies that have come up with one being better than the other. It's not very lopsided at all. People tend to think that the centrifugal pump is heavily lopsided for its benefits. The studies actually don't bear that out. Now, I think, though, you have to take some of these studies with a grain of salt. When you go into long bypass runs, the differences then, I think, become a little bit more clear. So I'm just giving you an idea of some of the studies now. Here's a study.
Bharat Dutt, I know him.
You okay?
Yeah, I know Bharat. I know the author.
Oh, good. Okay, yeah.
And I know Gary Plancher, too.
In Journal of Extracorporeal Technology, 2017.
Yeah.
And this particular hospital is right here in Orlando, where I'm at. I don't work there, but it's the Heart Center at Arnold Palmer Hospital for Children. This was presented April 17th at the AMSEC International Conference over here in Tampa. But Dr. Dutt and all of his colleagues and the perfusionists are all authors on that, and the physicians, and they looked at the impact of roller pump versus centrifugal pump on homologous blood transfusions and pediatric cardiac surgery. Now, in pediatric, roller pump and centrifugal pump really get to be put under a microscope, I think, more so than in adults. So they looked at 240 pediatric patients, 140 centrifugal pump patients, when 100 were on roller pump. In the roller pump group, they have found a decreased priming volume. They had an increased hematocrit, they had a decrease in intraoperative blood transfusions, and they actually saw a decrease in mortality in their particular study as well, in the roller pump group. And that's because of the prime volumes were lower. So there's many studies. You guys can look up so many studies, but I wanted to make a closing comment on all of this and kind of bring it full circle. In researching the clinical benefits of one type of pump versus the other, which I did, not an exhaustive search, but a pretty thorough one. And when you look in terms of hemolysis, inflammatory response, the levels of cytokines, complement activation, interleukins, all the types of things, inflammatory responses people have tried to look for, fibrinolysis, amount of platelet activation, on and on, one is likely to discover many contradicting studies. There are likely as many studies claiming one type of pump is better than the other in many short-term and long-term clinical aspects. For example, there are studies demonstrating centrifugal pumps being more gentle, less hemolytic, etc. However, there are studies that conclude that even a poorly occlusive roller pump is less hemolytic than a centrifugal pump. There are many studies that have found no clinical difference in outcomes. So in the end, it remains the education of the perfusionist to research and conclude for himself which is the best for your patients. However, I will say this, there is one standout characteristic that centrifugal pumps have vastly above roller pumps, and that is, in my opinion, in the area of safety. All right, guys, thank you so much.
I'm glad you finished with that point, because I think that in the old days, okay, and I think that this exists in a lot of places still today around the globe, depending on where you are, where you use the roller pump, that the centrifugal pump is clearly much, much safer because of what you had articulated earlier, in that the positive displacement pump is not resistant dependent. It's going to pump against whatever, and it is going to pump air and not deprime and then just not function any longer like a centrifugal pump will. So in that regard, I agree with your point 100%. But in today's technology, where we are with the systems we have in place, level sensors that will servo regulate, you know, high and low, and speed your pump up and slow your pump down depending on where you are. Air bubble detection that will, actually you could have three. You could have a high, a low, and a cutoff point. So your pump will literally shut off before your oxygenator is fully drained. You can have an air bubble detector at the outlet of your venous reservoir, proximal on the negative side of your roller pump, which will shut the pump off so that you don't deprime your roller pump. Your arterial boot is what we call it, right? You have pressure limiters that will turn the pump down, that will servo regulate it down, alarm, and even turn the pump off if it exceeds a certain level. And you can set that level at all kinds of various places. You have automatic occluders for centrifugal pumps, for example, that you can put on it. And if it is retrograde flowing, it will clamp down on it automatically. And you have the same thing on the venous side where you have these automatic occluders. So technologically, I think we have the tools to make roller pumps truly equal in safety to the centrifugal pump. But where it becomes the sticky wicket when we talk about affordability is the cost of that technology, and then having that sense of confidence that you can rely on that technology. Because, you know, the number one failure associated with anything that is technologically advanced is the technology failure itself. So you know, the system failed, didn't work. That's my thought. I think today roller pumps really can be used with equal safety to that of a centrifugal pump, if you want to spend the money for the systems to make it safe?
You make a very good point, except I think you're missing one huge factor, and that is the human factor, which is, do you have not only the money to buy these devices, do you have the patience and the diligence to set up every one of those safety devices that you listed? Because if you're going to use a roller pump as safe as a centrifugal pump, you're going to need a series of at least several devices. One, to prevent high pressures, like you said, and maybe your low level, your variance of speed as the level gets lower, you ramp down. You're going to have a number of things hooked up correctly every day, calibrated, tested, and because they alarm and they annoy you, that the human person factor doesn't turn them off, which all of us have done, even with far less alarms than what you're talking about. Now, I did work at a place that had an arterial line safety occluder in case the flow became retrograde. We had 4 perfusionists. Not one of them, including myself, put the arterial line through that occluder because there had been instances where it occluded the line because the flow went close to zero and you couldn't get it to unocclude.
Yeah, that's pretty scary. That would, and that's one of my big fears too. So that's what I said. The technology is there, but is it reliable? Can we depend on it? Do we feel like, the technology itself isn't going to, the thing to save us isn't going to be what sabotages us?
Yeah,
or the patient.
Has it ever happened? I'm sure the answer is yes, Joe, probably more than once, that you've worked or you know of perfusionists that have worked with a surgeon and they accidentally clamped the arterial line instead of the venous or whatever it was they were trying to do. Or the PA, which happened to me in 2017, I had a centrifugal pump and all of a sudden I just stopped flowing and I had no idea why. We started checking it out. I alerted the surgeons. The PA backed up 4 or 5 inches and the loop was down by his waist, had completely kinked it off 100%. I'm not sure what would have happened with a roller pump. Like you said, if I had those alarms for high pressure and so on, I guess it would have saved me. But with a centrifugal pump, I would say in terms of safety, it takes care of a whole lot of those things for you. You can still make a big mess and you can still have a big disaster. Don't get me wrong. It still pumps micro air. Micro air, it'll continue to shoot it right out the outlet. A lot of them, especially the ones with fins, will pump quite a bit of air. Will it get past your oxygenator? Will it get past, to the patient? Well, hopefully not. But
John, really,
what are your thoughts about that?
The two. Well, I'll tell you my thoughts on it. But the two mantras are out by noon with no balloon and what's a little air among friends. I mean, you do a mitral valve, and then you de-air the heart, and then you take the cross clamp off, and you look at the TEE, and it looks like the universe has come alive. It's there. I think that micro air. Most of it doesn't get through the oxygenator, and what does, I don't think has clinical significance. Though I think we should do what we can to reduce and eliminate it. But we do an awful lot of surgery, and I think atheroma causes more problems than does low flow states. In fact, cause more problems than GME, micro GME. My thoughts on what you just said are I agree with you. I just wanted to be provocative and see where you would go with it. I think roller pumps are less expensive. I think that they're more affordable for some places, some people, but they come with in my view, a much higher risk. Even with the safety systems in place, if you're flowing 5 liters and you have a pump cut off at 250 millimeters of mercury, 300 millimeters of mercury, and you're flowing 5 liters and somebody just acutely clamps your arterial line at that flow, the delay in the transducer seeing that pressure and then the computer sensing that and then sending the signal to cut the flow, the pressure is going to be 1,000 and something bad is probably going to happen. You would have to set it very low at an intolerable rate, I think, in order for it to work effectively. And then if you, for some reason, you were using, those isolators and it leaked and now your transducer was already, the little diaphragm was already at the top, and it wouldn't go higher than that, even though it is higher than that. There's a lot of failure points, too many in my view. So yeah, I agree with you. I think centrifugal pumps are safer, and it'd be my preference if I had say in it to use that. But I know there are places here in the United States that do use roller pumps, and they use them, they do use them safely, and some of them are pretty big academic centers. I mean, they're not small places.
What do you think the percentage is? I bet it's a little higher than most people would think for roller pumps.
Well, can I guess? I mean, I'm going to guess. I'm going to say it's a 60-40 split, 65-35 split between centrifugal and roller.
If you include pediatrics, it's probably that high. But I was talking about it. I don't know the answer. I'm asking your opinion.
Oh, I don't know.
I'm going to say adult only. It's probably 20% of the people probably using roller pumps for adults.
Mm-hmm. Yeah, I always act surprised when I see somebody that's using, or they tell me they're using a roller pump, but yet at the same time it's happened. I've had it happen. I've had people tell me that multiple times. So
I will say one thing that people forget. If you're a centrifugal pump user, which I have been almost my entire career, you use roller pump every single day. It's called your cardioplegia pump.
Yeah.
Unless you're using a Quest, I guess. But you use roller pump.
Well, that has a roller too.
Yeah, I guess so inside there, right?
It does. Yeah. Mm-hmm. It's a roller pump. Yep, it's a roller, and use it for other things too, suctions, vents, and so forth. You have to have roller pumps. Roller pumps are, they have to be used for a lot of things. You can't do centrifugal for a lot of the other things that we do, like venting and suction and.
I was talking about positively pumping fluid, hopefully air-free fluid to the patient. The suctions are, we're using it in a different fashion. But you do pump a roller pump every day, even though it might be a centrifugal perfusionist if you have a roller pump cardioplegia. So
yeah, that's true. I agree with that.
And your train of thought about what can go wrong with a roller pump, all the things I just hit on, apply. Every time you hit that cardioplegia pump on every 15 or 20 minutes, the roller pump principles of what can go right and wrong, cavitation, too high of pressure, whatever it is you want to talk about.
Yeah. And if you're using those dual roller pumps, then you've got two going at the same time. Have you seen those, the dual roller pumps where you have one with the blood, one with the cardioplegia, and then it mixes downstream?
Yeah.
I like those pumps. But anyway, so that was really good, John. That was very interesting, I thought. And I really enjoyed it. You took a tough subject and you made it at least fun to listen to and provocative, and that was good. That's what we like. Do you want to do this? I think the girls are ready to come in. We have Stephanie and Amber. And do you want to take just a one? How long would it take you to get them all looped in? 4 or 5 minutes? Okay, so John, can you hang out for 4 or 5 minutes?
Yeah.
And we'll bring it back.
I'm off work now. I did my shift change and I'm off work, so I'm good to go.
Good deal. Okay, so 4 or 5 minutes. We'll be right back. Everybody at home, stand by. Nice conversation with 2 really seasoned perfusionists, 1 moderately seasoned perfusionist, and I'm sorry, let me rephrase that. 2 really old perfusionists that you're looking at, 1 seasoned perfusionist, and then 1 relatively new perfusionist whose father happens to be a perfusionist at the Mobile Infirmary and is the department director there. So here's a daughter that followed in their dad's footsteps. So we'll be back in 5 minutes. Just break sign.
did that before.
That's
Okay, and welcome back everyone to the show. Happy to see everybody. There is Amber Maurer, and John Ingram's back with us, and Stephanie Ebus, and there was Rodell over there. He ran off screen, but Stephanie and Rodell are both perfusionists, a married couple. Amber Maurer, who we just talked about, is a perfusionist. How many years? 2 years now, Amber?
1.5 years.
1.5 years. You got to start. You got to start being like the rest of us. Okay, 1.5 is 2. 2 is almost 3. You just always sort of have to add a little bit to it.
2 years it is. I'll take 2 years.
Exactly. Take 2 years. Right. Exactly. 1.5 is close enough. And then of course Stephanie and her husband, Amber's dad, is a perfusionist. I said that earlier, and is the department director at the Mobile Infirmary. And Amber has followed in her dad's footsteps. And that's really something to be proud of, I think. I talked to him on the telephone, and he is very proud of you. I will tell you that. Stephanie, of course, has been a perfusionist now for over 20 years, right? 20 years?
Right.
Over 20 or just 20?
99.
99? So 21 years. Yeah, 21 years. 21. She's 21 years old today. And Stephanie has been a perfusionist, graduated from Ohio State. I think you all know her from previous programs, and of course John was just here. So I'm just going to tee this up because I think we have really, what is that noise? Huh?
I can't hear him.
Okay. Somebody making coffee over there? Or, yeah, Rodell must be. Rodell is cleaning with the vacuum?
He's hiding from the camera because he needs a haircut.
I understand. Very good. Okay, so I think we have some real interesting generations here. We have John and I, who are really old. We have Stephanie, who is an experienced perfusionist. And then we have Amber, who is relatively new to this profession, although she grew up in it. But still, I think, so those are some interesting perspectives. And her dad and I are contemporaries in terms of time. In fact, I think he has a couple of years on me. One of the few people I know that have been doing this longer than me. There's not a lot of them left. I'm holding out. I want to be the oldest practicing perfusionist on the planet, or the number of years. So that's my goal in life. Okay, that'll keep me alive for a while. So I want to tee this up with, what is perfusion? Is it a job? Is it a career? Is it a profession? Where do we fit in the world of medicine? Are we, like shift workers? Are we, most of us aren't really. Some are, some aren't. But how do we view what we do, what our responsibility is, what our commitment needs to be, and then how do we balance that against our philosophy about work and work-life balance? So I'm going to turn this over to Stephanie, Amber, and John, and you guys are going to be up, and if you have a question for me or you want me to add anything to it, I will. But I want to hear from you guys and sort of get a perspective from someone besides myself. So Stephanie, why don't you lead it up?
Okay. Well, I think that we clearly are professionals. A professional is identified as having a clear objective, a clear skill that they've learned. So we've had specialized training, and we have a set skill knowledge, we have educational knowledge, and we have formal qualifications. So definitely I would call all of us professionals. As far as a career or a job, a career is what we would say our professional journey is. Desire, I feel like you have a career when you have a desire for upward growth and long-term goals, compared to just, so every job that we have as a perfusionist or anything related to this profession is a part of a continuing growth. I think that when you have that career mindset, you have motivation to keep learning and learning from your experiences, educating yourself, growing in development opportunities. And we measure that career by personal satisfaction And also people measure career growth and feel like they're in a career wherein they feel like they're advancing, like titles, positions, achievements, advancements in work, and pay, obviously, also. For me, what I see in our profession is the nemesis of career and career stagnation. So once we feel that we're no longer desiring to grow, or we no longer see opportunity for growth in our own job, then your career mentality switches to a job where I no longer want to keep learning. I think I'm doing great the way that I am. That starts to lead when you feel no longer like there's anywhere to go in your career. The burnout feeling, the stagnation, and you start feeling like you're just there for a paycheck. And I think that can hit us any time in our career, and we can bounce back from it. Sometimes you're at a job where you start to feel very stagnant, and that's when maybe you know it's time to move on to something that makes you feel more personal satisfaction and growth.
Yeah, I think those are great thoughts. Did Amber, did you want to chime in on that?
Absolutely. So, go ahead. I would say I would agree with Stephanie on that aspect of perfusion being a career and it having a stepping stone between, doing anything between research or teaching or some type of administration job. And then some people that find it as a job, like you said, the burnout, where they're not feeling like they're doing anything other than getting a paycheck and just pumping and going through the motions. That's when you see people leaving, and not to hate on sales reps or anything, but you start to see people growing out of the perfusion world onto other health jobs, including the medical sales, working with the valve folk and that kind of things. But as far as career versus job, I think even, it being a career and that being a stepping stone to go and teach or do some type of medical sales, that's still, you're moving up in your career.
Well, Amber, that's an interesting point. I'm curious to know what the other panelists may think as to whether or not you think medical sales is a step up from clinical perfusion.
If medical sales is a step up from perfusion?
No, I was asking you that.
Yeah. I think to be in the medical sales with cardiac related supplies and equipment, then you should have some type of background of cardiac surgeries and kind of know what's going on in the OR to be a successful medical sales rep. My background, I did medical sales, collecting placentas for a couple of years, and that was my stepping stone into perfusion, into the OR world. So I had some type of OR experience and knowing the kind of morale and temperament in the OR settings. So either or, going from medical sales into perfusion or perfusion to medical sales, I think it's a good segue to those that type of job or career.
So give an old person slant on this.
Yes, would love to hear from you, John.
So I just wanted to get a real quick. So Stephanie, you graduated in '99. Is that true? And then Amber, you graduated a couple years ago. By the way, what you always do is you count your years of perfusion when you tell people how many years you have until you have enough and you can chop those off again. So that's just a little tricky. But anyway, my thought about career or job is I think that feeling that you had, and the reason I asked when you graduated, but what feeling you had when you either first heard about perfusion or you were in perfusion school and you're getting close to being done and you're just going through the whole process, that feeling you had about the field, that excitement, hopefully it was a big excitement about what you are doing, what you're getting ready to do, that feeling is what I hope never leaves. Now, I had 20 years and I got out of perfusion for quite a while and I came back about 5 years ago. So I had when we graduated, remember this, Joe? The burnout average was 7 years. people only lasted the average person lasted 7 years in our field before they got out, meaning some got out much sooner than that. So I went 20 years, and I would say the last 5 at least, I was probably feeling that burnout where, I loved getting called in and I loved coming in. And those last 5 years, it wasn't like that anymore. It was drudgery. And then, I was able to retire for a while and come back. And that really did me a lot of good. But I guess my only concern is, and even in our generation too, we had the same type of thing. We didn't have every person in our class was just going to live, eat, and breathe this 24/7. There was always a percentage who really just looked at it as, well, it's a job and I'm going to make money and it's a wonderful thing to do. And I'm sure that happens in all ages. But that excitement that you had, always wanting to do the best, that excitement of taking care of the patient and learning and always wanting to be better, that I think is transformative to making this even something even beyond a career, almost like your life's calling and your life's worth. Mm-hmm. And I think, I hope that still exists a lot today. I'm so detached and removed from new grads and perfusion schools that, I hope that still exists quite a bit today. I think it does.
Yeah, I think you bring up, all of you bring up some excellent points. And I think, Stephanie, starting with you, discussing the ability to grow within the field, having other things to do, finding what it is in the perfusion industry that you have a passion for. It may not be like what your boss might think he or she may want you to have passion for, but it is, it's you have to find what it is that you find stimulates you to want to do this job and to consider it something more than a job, that it's a career and something that you're going to do for the duration of your professional life, unless you decide to, go back to school or go into a different industry. And I mean, all those are, very possible. Certainly there's a lot to do in perfusion, from academics to just doing the chip shot cases in a place, to doing things like this program, to doing consulting work. I mean, there's so many things you can do. And some people find, I think, reward in different, you got Corona? In different things. They find pleasure, they find satisfaction in just doing a good job on each case that they do. Some people want to do other things, and you have to respect that, and you have to find the job, I think, that gives you that best opportunity to do those things that helps to keep you interested. I don't want to belabor the point, but I've had my moments too. I've been doing this for a very long time, but I did leave the industry from full-time to part-time. I didn't leave it entirely, and I continued to work because it paid money. And I did something else on a full-time basis for 4 years, and it was very rewarding for me. I needed to do it, but really, I do love this profession. I started, at a time when it was, back in '77 is when I started my training. I was, relatively fresh out of the military. I had worked as a EMT at Charity Hospital in New Orleans just before going to perfusion school after I'd gotten out of the service. I've been in it, with the exception of going part-time for those 4 years in the early 90s. It's what I've done. And I guess my point I'm trying to get to is I feel it's our personal responsibility to find what we need to grow in whatever our job is. And if the job doesn't provide that for you, then I think that's where you start to have to consider, well, what's important to me? And if I really need this, do I need to go someplace else where I can have that? And of course, we're a very small fraternity, so that may not really exist. Amber, in your particular circumstance, I think going to a medical device company or something like that is something that interests you.
I'm sorry, you're cutting out a little bit for me on my side.
Yeah, I don't know what that is. That sounds like a train going through somebody's house. I have no idea where it's coming from. It's not coming from here. But with that said, to me, that doesn't float my boat. Now it floats yours. And I think that's where we're different. People are different. All kinds of different people go into perfusion. And John, to your point, I think that jobs are sometimes are hard to find, sometimes they're easy to find. We've seen that pendulum swing back and forth. But there are people, and I've been places for temporary assignments or whatever it may be, that the environment was just toxic and corrosive, and people were miserable and they hated their jobs and they hated going to work, but yet they stayed for a whole variety of reasons, I guess. But I don't know. Those are sort of my thoughts about how you three view this. They're three very different perspectives, but all of them have legitimacy. What say y'all? Steph, you go first.
John, I'm curious. You were talking about the 7-year burnout. Why do you think that happens with perfusionists?
Well, I don't know if the numbers are still that today. I'm talking about in the 80s and 90s and 70s. In our perfusion school, we were told, well, the statistics were the average person burned out at 7 years. Some lasted 3 or 4, and some lasted 10. But the average person after 7 years had to say, I've got to find something else. I got to, find something else to do. I have to go into sales. I have to get out altogether. I'm not sure what people did at such a young age after 7 years. I'm still wondering, but most of the people that I know, somehow managed to stay in quite a bit longer. But I think the reason was back then is that the average person worked 70, 80 hours a week. And surgeons were, I think, on average, a lot more brutal, less forgiving. I think that you gave your life to this a lot more than a reasonable person would be willing to do. And I had a friend of mine who, within a couple years of graduating, put a bullet through his head in his hotel room. Wow. In his second year, and he was a perfectly fine perfusionist. I don't know what led to that, and I think that's happened a time or two. What do you think it is now? Does anybody know what the burnout rate is for in the last 10 or 20 years?
Yeah,
I know.
Go ahead, Steph.
And I was looking at dental school or doing something else, and I'm trying to think back why, because I don't think that it was a thing that I was like working so much, but I think maybe at that time I didn't see any way to grow, or it just seemed like a very stagnant type of job. Like you work those first few years to get so good and confident, and then it just kind of levels off, and then I had to then adjust and find new ways to channel that energy in positive ways. Like now, just doing small things in the group and feeling like I can improve things in our department, or work with the surgeon to do something new and mentor younger people coming in. I found satisfaction in that.
That's very nice. I like that. Amber, you're 2 years into this business. How long? I'm sorry? You're 2 years into this business. How long do you think you're going to stay?
How long do I think I'm going to stay?
Yeah.
Oh, this is my career choice. I have no plan at my 2-year mark to be leaving this profession. I don't know what else I would do at this point. You put in, your 4 or 5 or however long your program is of schooling. And I feel this is my calling in life to do. And like kind of what John was saying, of people coming into this thinking, oh, I'm going to make a bunch of money. I think those are the type of people that will burn out earlier, where for myself, and I know my classmates that I graduated with, they had a passion for this job or this career. And I think if you have that passion you did and that excitement you had in school and throughout your training and for the couple, your first couple years of practicing, I think that will help with the longevity of keeping perfusion as your career long term.
Very good, very good. I like that. I like
Joe,
that.
can you hear me okay?
Yeah, little feedback, but not bad.
Yeah, I've said this for very many years. When it comes to making money, not only in perfusion, but actually in any field, but it's very true in perfusion. This is the secret. People always want to know what the secret is. The secret to making money, the most money you can possibly make, is to forget about how much money you want to make and think solely about how good of a perfusionist you can be. If you are absolutely phenomenal perfusionist, the money will find you. That's the mistake people make. The money will chase you down because people want you and surgeons want to work with you. And when you go to leave, everybody comes to a stop and says, wait, how can we keep this guy? Other people say, how can we get this guy or gal? Okay, so if you don't get those, you're not in a standpoint, you're not negotiating from a standpoint of strength when you are money first and my performance level second. That's the mistake that people make. I think in perfusion, it's huge. It's probably big in most medical fields, but it does apply in almost anything. So that's been my secret, and I didn't figure that out. I just was so hungry in my field in my first few years that I just soaked up every bit of knowledge. I went after it, and I found people coming to me, and I said, wow, they're coming to me not because of any other reason. They've seen that I published a few papers. They've seen this, they've seen that, they've seen the other thing. When they ask a question, I have a pretty intelligent answer. And word gets around real quick. People want good employees. Right, Joe?
I think you're 100% right. And I actually, that was a very insightful statement that you just made, and something that I agree with 100%. I think that, but you also, along with being a very competent, capable clinician, you have to be humble. I think that you have to, this is a very competitive business we're in, and perfusion, I think you said it was huge, but I think it's very small. We have 4,300 of us. It's not a whole lot. So we're a very small fraternity, but we're very competitive. But you should be able to be competitive while still being a facilitator for everyone to be successful from a clinical perspective, and personally too. You have to be a nice person. At the end of the day, you just can't be a mean person, and you can't be selfish, and you can't be arrogant, and you can't be pompous, and you have to stay humble, because I've learned, look, I've been through it, anything can happen to anybody at any time. And yes, years ago, John, I agree with you also that the environment was horrible. It was a horrible environment for many years. And surgeons were sometimes just abusive, and it was unnecessary. And I'm talking about the old guys, and they would attack you and blame you for every bad outcome or every issue that happened in the room. And there was a high suicide rate. I mean, it did exist. AMSEC, in fact, had a suicide hotline manned by a clinical psychologist who was available essentially 24/7. And so it was just amazing to me that actually existed, but it did. And I'm a different kind of person. If you treat me like that, I've been through the military and some other, I guess systems where I got a pretty thick skin. But there are some people who that kind of thing really affects them very deeply, their ability to process it. And that really comes down to, we're all human beings. And people are different. We're all the same, but we're different, and how we manage that kind of stress. So, but I think perfusion has gotten much better. I think surgeons that we work with today value us. By and large, there's always the exception, but there are exceptions now. I think now we have really, this profession has come into its own of really being an integral part of the overall heart care team and a valued member of it, to especially the surgeons and even the nurses and everyone else. We do a lot of teaching, but we also learn a lot, and we respect each other. And I think that respectful environment has made a huge difference in what this profession is today compared to what it was, John, for us back then, and maybe even for you, Stephanie, in your early days. I don't know exactly, but I know there was a major change somewhere around, late 90s, early 2000s, with how it is now evolved to where it is today, which I think is a much, much better place.
It seemed like for the first 10 or 15 years, including perfusion school, every single thing that I learned was learned by tough love. You know what I mean by that?
Oh, yeah.
It was beat. Nothing was ever given to you nicely. Everything was beat into you. And let me tell you that is a long, lonely road, because every night you go home felt like a kick in the stomach. I don't mean perfusion school, I mean on the job. And I had to come back every next day and work with that same surgeon all over again, because there was only one or two surgeons a lot of time at the hospital. We worked with this thing every day, and if that's what's rough, every day, some days could be good, and some days could be just terrible.
What is it? Stephanie, could you mute your mic when you're not talking? Apparently, they've figured out it's coming from your area. So could you just mute your mic, and then John can talk, but when you talk, unmute your mic. It's on your screen. So John, I'm sorry, but we really couldn't hear you very well.
Okay.
And did that fix it?
Can you do Amber too?
Oh, Amber, can you do yours too? Mute your mic as well, if you know how to do it.
Is that better, you think?
Yes, now we can hear you. Go ahead, do that again. So if you could say that again.
That, for what seemed like the first 15 or so years of my career, including a couple of years of perfusion school and even the first jobs, almost every single thing I learned was beat into you, like in tough love style. You know what I mean? Nowadays, I have conversations with surgeons, and they're like, like equals, like friends talking to you. That didn't exist years ago. It was a very, very much, a master-slave type of conversation, and you got things beat into you. And one thing about that strategy is that, I guess, if there's a good side, is you never forget it, because how could you had to suffer so much learning it. But it's painful and it's stressful, and I have no doubt I lost years off of my life in the first 20 years of perfusion, having it be so brutal for so long, and the lack of sleep, the number of hours, and the on-the-job stress, all of that, Stephanie, as you asked before, 7 years is not a very long time, when it probably took you that many years to even get to the point of graduating perfusion school, because a lot of us had a background before that in college, and then you do another couple years of perfusion school, and then for it to only last that many years because it was that brutal. It was kind of a sad commentary, so I'm kind of glad it lasts a lot longer now.
Well, John, I don't think you look bad for 35, frankly. I think you look pretty good.
I'm 35 in dog years, Joe.
I hear you. Right. Okay, so Steph, why don't we do this? Why don't you, if you'd like, to respond to John, and maybe some closing thoughts about what you think about all of this, and maybe some advice you can give to the younger folks like Amber, and maybe even some advice you can give to the older folks like John and myself.
Oh, I don't think I can give you guys any advice. I think I've enjoyed listening to you, and I've learned so much, and I appreciate all the programs you guys do and all the work you put into this. I kind of have seen over my career that when people start feeling trapped, like we're so specialized, And it's not easy sometimes to move to another job because, in Houston here, there's like a lot of jobs, but sometimes you live where if you want to make a change, you have to be willing to uproot your family. And I noticed it can create a lot of bitterness in perfusionists that if they, what do we do with this skill set if we no longer want to be perfusionist and we're used to having the pay that we have, and then where do you go from here? And I think that for me, I had to get back to being really grounded on I'm so grateful for this profession and for my career, and if I'm really not happy, I need to make a change in myself to go find I love doing perfusion, so there's a world for me here, so I just needed to find the paths and avenues to make it fulfilling long term. And so the way I feel now at 20 years, I feel like I'll continue to grow, and I hope that never changes for me.
That was very nice. Amber, what are your thoughts?
I think with the younger generation of perfusionists, it helps, and the kind of frame we're in right now with the social medias and perf web and the conferences and the newer technology on equipment and stuff that kind of help us, want to stay in it for the long run. I think from where perfusion started 50 or so years ago to where we are now definitely has progressed in all sorts of aspects. So I think it's still going to be challenging down the road, but I also think that the time frame that we are in right now with perfusion and the technologies that we have and the outlets that we have to continue to grow and to learn, I think that will help too with that burnout feeling and such. But I really appreciate what Stephanie had to say, and definitely what John was saying. That put a lot more perspective in my eyes in regards to the field as well.
Good, that's really good. John, what are your final thoughts?
Yeah, I think you guys are hitting right on it. Joe, and I'm not just saying that because you're such a not a nice guy. I'm saying this because you have to like the boss that you work for. That is really, really a big feeling, a good feeling to have if you like the person you're working for, number one. Number two, I think, Joe, you said it too, you need to try to work in a non-toxic environment, and that may not depend on your boss. Like Joe, you're different perfusionists go to different hospitals. You're not necessarily there, but the environment that's created at that hospital are what your perfusionists have to deal with every day. So if you like who you work for, if you like where you work, but even if you don't totally like it, try to improve it. Try to talk to the people that maybe are spearheading the negativism in your environment, and hopefully your job changes will be minimal. I think there are advantages to changing your job every now and then. There's some pluses to be gained from that, but from someone who had my own group also and had as many as 18 or so people working for me at one point, fortunately, a lot of my people stayed for a very long period of time, and most of the feedback I got was, they liked the way I treated them. I tried to treat them fairly, and that's another thing. As a boss, you treat one person a little bit better than somebody else, and that turns negative all the other people who didn't get treated that way. So, as a boss, it's very important that the people like working under you. That helps people stay a lot longer and be a lot happier.
Well, the only thing, John, that's very true. I agree with you 100%. But there's liking and there's respecting and there's, Stephanie will tell you that there's always a divide. I think I have told her this as she has moved into the management role within this company and is going to continue to grow within this company as the company continues to grow. There has to be a separation. You can be friends, but you really can't be friends. And I think you all know what I mean by that. There's a divide because you're supervising people, and you have to avoid that favoritism or even the perception of it. Now, in my case, Min is my favorite, number one, and that's never going to change. And number two, Stephanie has only thrown her phone one time as a result of me. So, and I'm very proud of her for that. So that's my closing comments. I'm very, Stephanie, do you still have that phone? Does it still work?
It does, but don't push me.
See, that's what I get, John. That's how it is. That's how it is here at HET. But this is about perf web and perfusion education, so we'll get off of that. All I can say is I'm gratified and I'm humbled by everybody here on the panel that was willing to take time out of their day and to do this and contribute to this conversation. We've gotten a whole bunch of comments on Facebook and YouTube, and I'm assuming Twitter. Magic is over there with that. But a lot of people have made some comments about jobs. Just this one topic, short conversation, nothing formal, but it's really good when people can get around and talk and just, you know, really have a discussion about how they think, because sometimes people think things and they wonder, am I the only person that thinks this? And I think having these discussions really helps people to feel that they are not out there alone with these feelings, because perfusion, as great a job as it is, and it is a great job, not unlike the surgeons, at a different level. And I don't want to be arrogant here and think that we're surgeons, because we're not. We're mid-levels, and what we do, it's very important. But it's a lonely place. Perfusion is a unique and lonely profession, because when you are by yourself and most of the time everything just goes swimmingly and everybody looks at you like, man, you got the best job in the world. I mean, this is ridiculous. You make all that money and that's all you had to do today. But when it all goes wrong, when it all's falling apart and everybody is just looking at you, they're looking at you but backing away at the same time, because they don't want any part of this disaster that you are there to manage and deal with. Teamwork really helps, but when you are by yourself, and that is going to happen, and it happens a lot, we work independently, you really have to know what you're doing and be on top of your game in order to have successful outcomes in things that no one imagined you would be able to get through or pull off. So it is a unique profession. It's an enigma. It's misunderstood. Most people don't even know what a perfusionist is. They think we sell perfume. They have no clue what it is. But what we do is so critical, and we have so much influence on the outcomes of patients that I think that it is sometimes misunderstood and frequently underappreciated, because when the case goes well, it's generally because we've had a good day. My final thought. Anybody else? There's silence. Huh?
Well, I'll tell you one thing in relation to what you just said, Joe. I once had a surgeon with the patient basically had a stroke, a regular cabbage case, normal case, and the next day, next couple of days, patient didn't wake up, and it turns out that, somehow the patient had a stroke. And the surgeon was trying to blame me. He was trying to blame me for the fact that this patient had a stroke. And I said, I tell you what, I said, it was so rare. We had a very low complication rate. We hardly ever had this happen. We had really good practice where I was at. And I said to him, I tell you what, I said, I'll take blame for this stroke if I get credit for every one of the patients that didn't.
Yeah, exactly. Yeah.
He's like, oh, no, he didn't want to go over that. So then he stopped blaming me for the stroke.
Well, I used to go to work, and there was a surgeon I used to work with, and he was one of those guys. And, I just got fed up with it. So I took a piece of tape and wrote saboteur on it and just put it around my cap, my OR cap, and wore it all day, because that's just what he thought I was. So I may as well just announce it. I'm just here to sabotage you, that's all. And he didn't see the humor in it. I did, but he didn't see the humor in it. So I do want to tell you that Gibby Roseland says that younger perfusionists, so that's you, Amber, are very lucky with all the technology and more experienced teachers you have. Old respected perfusionists were teaching themselves. and researching and teaching themselves. And some of that's very true. Somebody had to teach us. I mean, somebody did teach me, but there is a level of truth to that. A lot of what we do today is derived from what happened way back when. But you know, we're going to be gone one day. You, Amber, are going to be there. Stephanie is going to be me, and she's going to. And you guys are going to be sitting around talking about me. I'll be somewhere. I'll be probably in an urn somewhere, and maybe you can get a piece of me. You know, you guys can wear me like around your locket or something like that, Joe, the Joe locket. But you know, I think we all teach each other, and I think that's a good thing. We all, Facebook, another. Oh man, okay, I'll do one more, because we got to go. It's 7:30. I'm getting tired. I don't see it. I don't see it. I mean, it doesn't matter how many times you tell. You can tell me the last one. You can tell me the first one. I see nothing. Hold on.
So, Joe, I want to come to Amber's defense here while you guys are doing that. In 1987, when I graduated, the people before us said the exact same thing to us. You guys have it lucky. You have membrane oxygenators. We had to use bubble oxygenators. The people before them said, you guys have it lucky. We had to use a Travenol bag. You guys have bubble oxygenators. The people before them said, you guys have it lucky because we had all reusable connectors and everything. It took 8 hours to clean all the reusable aspects of the oxygenator. That push that somebody in front of you has it easier than you never has gone away for 1,000 years. And so, you know, Amber, don't listen to what Joe just said. But no, really, everybody hears that, and I just think it's funny after all these years, you know, everybody keeps pushing that forward. And we heard the same thing from the people who graduated 4 or 5 years before us, that we had it easy and it wasn't as hard as they had it. You know, walking uphill with barefoot in the snow to perfusion school every day.
I had to do that. I had to walk uphill.
Yeah.
In 3 feet of snow, both directions, John. So I don't want to hear it. Solomon also says that
I don't take much offense to it, because I do believe, you know, with the technology and Google and YouTubes and stuff, you know, we have some advantages, but you know, 10 years down the road, there's going to be something new that that's going to be something like, oh, well, I wish y'all have it so lucky too, you know. So I think like what you're saying, every year or every so often, it's going to be the same pattern too. So.
Mm-hmm. Well, you know what? I've gotten old enough I could say it, and I'm going to stick with it. That's my story, and I'm sticking to it. Solomon does say that their burnout was due to slow surgeons. That can burn you out. Okay, that's true. Slow and bad. Okay, I've seen. I think all of us here have probably experienced that a couple of times in our lives. Different perfusion culture, you know, and attitudes being negative. And they say that they feel like today perfusion departments are better structured, more perfusionists are available, and therefore less burnout. I think that's relative. I don't know that that's 100% true, Solomon, because there are still places that have single perfusion accounts, and they're there by themselves. And I wouldn't want to do it. I've done it before. It was horrible. I wouldn't do it. But for some people, they actually thrive on that. And I think that's the thing. Find what you like. I didn't like it, so I didn't do it. I did it, didn't like it, moved on, did something else. I think we just all have personal responsibility to find our place and not moan and groan and complain about your job that you hate. If you hate your job and you're not happy, consider what you can do to make your job better if you want to stay there, or if it's intolerable and unchangeable in your view, then go somewhere else. But in the process of doing that, because we are such a small group, I highly recommend that you make and keep good colleagues. That doesn't mean everybody has to be friends, but like and respect each other for what we all collectively share in what we do, and the same, because we all have the same stresses in our jobs. That's how I feel about that. John, what do you say?
Yeah, absolutely. I mean, what I said before, You have to like your environment, the group you work for. They have to respect you. You have to respect them. And, you have to like the environment that you work in. And if you can change it, great. And if you can't, then at some point, it's better to try to move to somewhere else and get a fresh start. But toxic environments are prevalent, unfortunately, as human nature would have it.
But I think that exists in every profession, not just perfusion. I think medicine is much better than it used to be, but I think that it may be more pervasive in the medical industry, but it's not unique to medicine. I think toxic environments exist everywhere, including the post office. I mean, we saw that some years ago, right? I mean, how many times did we hear that phrase? So we've never heard them say, you're going to go perfusion. So that's, maybe it's not so bad. All right, we're going to say goodnight. It's been great. I've enjoyed it. We're through the second week. We have one more week of Corona 30 to go. The Friday next week, I am going to have a 6-pack of Corona sitting here to celebrate the end of Corona 30. And I'm going to ask all three of you to be on the program with your own 6-packs. And everybody else in the audience have them, and we're just all going to collectively have Corona to celebrate the end of Corona. So thank you all very much. We'll see you Monday, same time, same station. Thanks, everybody. I appreciate everybody. Bye.
Thank you, guys.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.